Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant. This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education and is co-sponsored by the Academy of Breastfeeding Medicine. Hi, Karen. How's it going?
Great, Anne. How are you?
Good. Let's dive into some hot topics in breastfeeding medicine.
Sounds good. I brought an article today that I want to share that was published in the Journal of Human Lactation, first online in November of 2023. And it is titled Early Bloomers, a nursing-driven program to support human milk feeding among late preterm infants in the mother-baby unit by Kate Standish, Ginny Combs, Barbara Phillip, and some others. And in the abstract, the authors remind us that late preterm infants, which is infants from 34 weeks gestation to 36 weeks and 6 days, have lower breastfeeding rates than term infants. Yet, few published interventions or guidelines exist to guide hospitals in managing them in the non-intensive nursery setting. The authors describe the development and implementation of an interdisciplinary hospital-based breastfeeding support program among late preterm infants not requiring intensive care. And this program, which they called the Early Bloomer Program, includes an order set applied at birth, immediate lactation consultation, availability of donor milk, parent education on late preterm infants, hand expression teaching and kit, including spoon and video link, and daily interdisciplinary team huddles. Yeah, not only is it a cute name, but they apparently rolled it out in the spring and had a lot of like spring themed things to get people excited about it.
And so this is at Boston Medical Center. Is that right?
Correct.
Where the authors are? Okay.
Mm-hmm. And this was developed with staff input using the diffusion of innovation theory and implemented first among early adopters before expanding to all postpartum nurses. Nursing staff received education on late preterm infant physiology and feeding and trainings on the Early Bloomers program through various learning modalities throughout the year. To further understand the strengths and weaknesses of the program, they surveyed nurses. 43 completed the survey, and they reported that they were more attentive to the needs of late preterm infants, more confident in their care, and more aware of possible complications and feeding needs. Areas noted in need of improvement included lack of overnight lactation consults and little involvement of labor and delivery staff in the program. The Early Bloomers program increased confidence in care and was well received by nurses. But well-designed clinical studies are needed to identify effective breastfeeding support practices for late preterm infants. So just to go into a little bit more depth, it is helpful for those who may not know that the rate of late preterm birth in the United States has been increasing. And this has been predominantly driven by an increase in late preterm births among non-Hispanic, Black, and Hispanic populations. And while breastfeeding is strongly recommended in all preterm infants to promote improved health outcomes, any and exclusive breastfeeding are lower among late preterm infants compared to those born at term. And breastfeeding rates are even lower among non-Hispanic Black late preterm populations, for whom only 66% initiate breastfeeding, compared to 79% of non-Hispanic white late preterm infant populations. And so this really highlights the need to support this vulnerable population. I just want to highlight a few neat things about the program, and then we can chat a little bit about how awesome this work is. So the setting of Boston Hospital is, it's an urban hospital with approximately 2,800 annual births. And in 2019, 85% of mothers were government insured. So that indicates a low income status. And more than 2/3 were from racially minoritized groups. Their mother baby unit consists of 30 postpartum private rooms with a level 3 neonatal intensive care unit on the same floor. And the hospital is baby friendly certified, and routine newborn care includes immediate skin to skin holding, rooming in, and couplet care. They have pasteurized human donor milk since 2016 in the mother baby unit for late preterm infants. And at baseline, they have 2 full-time international board certified lactation consultants dedicated to this unit.
So
They
the
have a
so wait, so the unit, you're talking about the unit for just for late preterms, or they have two lactation consultants in general?
they have
Yeah,
2
so
lactation consultants that are outside of the neonatal ICU.
interesting because this hospital, Bobby Phillips, many, many years ago, that she established Baby Friendly in the first hospital, I think that primarily had patients that were predominantly low income. And what was amazing was that she established this with very few or no lactation consultants, just with nurse education.
Oh, yeah. So when I lived in Los Angeles, I actually worked in one of the LA County hospitals in Torrance,
Mhm.
and we had 0 lactation consultants, and it was a baby friendly hospital. And I
Yeah,
think it's really, really interesting to see how, because I've moved around a lot. Thank you, military, that there are places that have a lot of lactation consultants that maybe the general nursing staff doesn't have fantastic skills because they sort of pass it off on to the lactation consultants. But sometimes having fewer, I find that the nurses take on more and the lactation consultants do more training of the nurses because it really is critical. They just don't have the person power to go around seeing every patient themselves.
exactly. Yeah. Yeah.
And also,
So,
I thought it was interesting that this, like to me, compared to I mean, I work in a really big hospital now with more than 10,000 deliveries a year. But the fact that they said there were 8 to 15 births per month that were late preterm, that's actually, it's a smaller percentage than what I would have expected for the size of births that they were
oh,
talking
interesting.
about.
Oh,
But
uh-huh.
part of the reason is this next thing, which is um, in this hospital, all infants who are below 35 weeks, so anybody who's 34 and 0 up to 34 and 6 are automatically admitted to the NICU for their entire hospital stay. Those born at 36 weeks or greater were admitted to the well baby unit. And those who were 35 to 35 weeks and 6 days first went to the NICU. And once they were observed to be stable for 12 to 24 hours, then were considered for transfer to the mother baby unit. And in my hospital, those babies routinely go to the mother baby unit first. And if they fail there, then they go to the NICU. And so that's why I'm used to seeing probably a lot more 35-week babies.
Yeah, that's true at our hospital too. They, if they seem fine, they're just monitored at 35 weeks. They're not going to a special unit. Yeah,
Mm-hmm.
but so just to kind of going back to the design of the study and what was reported, the outcome measure with the Bloom study, perhaps this is just one report that will gradually of a lot of data that's being collected over time, right? So they're doing all these steps, but in this particular manuscript, they didn't report exclusive breastfeeding rates.
Wait, time out. Let me stop you
Oh,
right there.
oh,
So at the end of this, maybe I should have said it at the beginning. This program was not designed as research or quality improvement. And thus, this report could not be interpreted as evidence on the efficacy of our approach. Limitations include lack of clinical outcome data, comparison group, or quality metric monitoring.
oh,
And
okay.
it is limited to the experience of a single hospital.
I
And
see.
so I think I was fascinated because I read through this whole thing and then I got to that at the end. And very often we stall out in my hospital because we're like, we want to make a change. But before we do that, we have to go and make this, preparation with the IRB or the QI, because if we do something and someday we want to write about it, you have to have done these things.
Right, exactly.
And I definitely think that it is important for us to do true QI and research. But I also found this to be very useful that they wrote this up because they did some really interesting things that otherwise we would not hear about. And it's better than us never getting around to it because we're like, oh, we don't have the bandwidth to do the like official
Right.
QI way or the research way to do it. But because of that, you're right. There's no outcomes data. There's nothing about rates changes. It's really just what they did and what the nurses thought about it.
And yeah, it's interesting. I mean, we have been doing those things for a really long time. And I think a lot of this is not published. And as you mentioned, having to jump through the hoops of things like IRB and um, randomization and, having a true good study trial,
Data collection.
data collection, it takes money, it takes time. We as clinicians don't tend to have that bandwidth. So we just do the things that make sense and it doesn't get published. And yet it can be very successful. And I think that we need to change how we document, how we publish and document and do this kind of work. I think if we can partner up with people who are just research and be the ones to collect the data and have a more formalized process of matching clinicians with researchers, I think we would be much further along. I would say that we've been doing this for years. We've had an altered protocol for our 35 to 37 weekers and with routine donor supplementation, lactation support, hand expression after feeding, just assuming these infants are not ready for prime time yet. And what we found, interestingly, is that the 37 to 38 weekers were falling through the cracks because they were kind of like that group. So we expanded the protocol to until 38 weeks. And
Oh,
what
that's
I meant,
really interesting.
yeah, because they were the ones that were getting readmitted. They're the ones where the babies were really sleepy and the pediatricians in the outpatient sector were just like, yeah, just keep nursing or, give the supplement. But the babies didn't understand, the parents didn't understand why the babies were so sleepy. And so when I would see them in the office, I'd say, your baby is preterm, it's a late preterm, but 37 weekers don't nurse as well as 38 weekers, and 38 weekers don't nurse as well as 39 weekers. And they have this aha moment like, oh my gosh, I wish someone had said that to me at the hospital. So I'm sort of glad, even though we're probably being a little bit more aggressive than maybe we need to be for some of these 37 weekers, it's kind of like, this kind of intervention sort of floats all boats kind of thing where everyone gets elevated and parents have better understanding of the fact that there's 37 5-day-old baby just needed extra support.
Yeah, I think that's a really good point.
Yeah.
Um, so when they designed this program, and I just want to say, like, to me, anybody who works in the hospital setting, who is interested in doing any sort of work should read this because I'm not going to go through every single thing, but I think it was really, really interesting. Um, Prior to implementing this early bloomer program in 2019, late preterm infants and their unique needs were not specifically recognized by the mother baby unit policy, while lactation consult and occupational therapist referrals were often placed. This was based on the need identified by the staff and not automatic protocols for all late preterm infants. Donor milk had been offered for all late preterm infants since 2016, but the consent process was burdensome, requiring the signature of an attending physician at the bedside. And this, I just wanted to stop and say, publishing this and just putting it out there, like more hospitals are doing an assent for donor milk and
Yeah.
not requiring formal consent is super helpful because we've started doing this. And on listservs, people are like, oh, we're having this roadblock. And other people are like, we're doing it this way. So having more people say, oh, it's acceptable to do it in a less burdensome way is really
Yeah.
helpful.
Yeah, definitely. Yeah.
Prior to implementation of the program, nurses had no official training in the unique medical problems of these infants, and the late preterm birth was not considered when making nursing assignments. And I think I just want to pause and say at some point, I think I did highlight the part where they included in their protocol every 4 hour vital signs for these babies for their entire hospitalization.
Wow.
And that is a significant amount of work. I think that sometimes when we try to do things like this in our hospital, we get pushback and we're told, like, oh, we don't have the bandwidth to do that. It turns out that when you are doing more than routine vitals in a newborn unit, you are providing intensive care. And there's a difference between intensive unit care and intensive monitoring of somebody on a
Mhm.
regular unit. And you can actually bill at a higher level. So these babies that are 35 weeks absolutely are on a bunch of protocols. They deserve to, have that done. And the billing, I love to talk about billing. The
Yes.
billing of hospitalized patients, you get both the bill from the providers, the physician who sees the baby, and there is also a facility bill. And that's
Right.
how all hospital billing works. But the way the facility bill is determined, it is related to what diagnoses are put in by the providers. And so if I am coding and I'm saying, I saw this late term baby and they had these multiple problems, then it's going to be a higher level facility bill. And that's how the hospital is going to have the money to pay the nurses to take care of these
Oh,
patients.
interesting. That's a good point. Yeah. Right.
Um, so there, the initial design of this program was done in August of 2017. So it took, more than a year of convening a multidisciplinary task force, including mother baby unit and NICU nurses, nurse managers, nurse educators, lactation consultants, and a pediatric nurse practitioner. And the task force reviewed existing professional organization guidance and developed a comprehensive clinical guideline for the care of the late preterm infant, in which lactation support was substantially emphasized. They framed the clinical guideline using the theory of diffusion of innovation from Rogers, 2003, which has 5 stages. Number 1 is awareness, number 2, persuasion, number 3, decision, number 4, implementation, and 5, continuation. And I was not familiar with this framework, so I thought it was
Mhm.
interesting.
Yeah.
The awareness, persuasion, and discussion were promoted by nursing staff, involvement, feedback, and communication at all stages of design and implementation. And they did a lot of, interesting things, like they had conversations and questions were like, what is your dream for late preterm infant care? What would you love to have in a policy, to really get sort of broad input? And the program aimed to, the goals were to increase human milk feeding, mother's own milk or donor milk, and to reduce hospital readmission in the late preterm infant. So it sort of had that, balancing measure.
Which makes a lot of
And
sense because it's a population that's really rife for readmission.
yeah,
Yeah.
absolutely. And that's really traumatic for families as well as quite expensive for the healthcare system.
Right.
The program emphasizes parent education and interdisciplinary feeding support. Parents were given swag bags with educational resources on the unique needs of late preterm infants and materials to support early hand expression and breastfeeding. Feeding protocols emphasize hand expression, offering donor milk when mother's milk is not readily available, and ensuring feeding every 2 to 3 hours. The donor milk protocol was modified to allow postpartum nurses to complete the consent with patients rather than requiring physician input. Feeding support was augmented via early automatic lactation consults and bedside teaching by nurses. And additionally, for every dyad, a team huddle to assess feeding was conducted at 12 hours of life and then as needed, and attended by the nurse, physician, IBCLC, parents, and other members of the care team.
That's huge. That's a lot.
And that was added later in the
Oh,
program. That was something
wow.
they discovered was needed. This program enhanced unit-wide attention to the late preterm infants by identification of late preterm gestation as higher need on daily nurse assignments. Previously, they only identified opioid-exposed newborns. Physical reminders were also implemented. Infants received a unique striped newborn hat and an early bloomer sign put on the crib.
Oh, great.
Finally, the program included an electronic order set to be placed, which operationalized the guidelines by automatically including orders for lactation consult, occupational therapy consult, delayed bath, delayed circumcision, vital sign measurements every 4 hours throughout hospitalization.
That's awesome. I love how they're in like a special group, like I think identifying in many different ways, like physically, they're given special educational, like the swag bag with stuff. I think that goes a long way in identifying the special needs of this group.
Yeah, I think that they had so many good ideas. That's why I love this article. In the second year of the program, they sent an anonymous online questionnaire to the staff, and they had a 79.6% response rate, which that is pretty impressive. Of the 43 respondents, they were all postpartum mother baby nurses with a mean of 10.1 years experience working in the unit, and they reported having cared for a mean of 10 late preterm infants since the program began. These nurses reported increased confidence caring for this population due to the program's education on late preterm infant physiology and its effect on their skills. Nurses noted they were more confident and better able to help prevent complications through better understanding of physiology at this gestation. And many described using this knowledge to help educate parents, finding confidence in their work by teaching moms about their late preterm baby and the difficulties they may experience. Others found the skills to support breastfeeding to be the most important. Quote, my ability and experience to support moms with positioning, waking techniques, pumping, and hand expression, etc., end quote. And also the nurses found the program components facilitated improved care. Many nurses described specific aspects of the policy as helping them to confidently care for late preterm infants. They remarked that teaching hand expression to mothers and making feeding plans with the entire team were important aspects of the care they provided. And then I think then there were a few concerns highlighted. Several respondents brought up concerns about the late preterms requiring closer attention and early breastfeeding support while still in labor and delivery. One nurse wrote, my biggest concern is babies remaining in couplet care on L&D. The early bloomers sometimes arrive to us cold and with low sugars. They can be forgotten because they are quiet and cute. Staff education in L&D would be helpful.
That's interesting. Yeah. So it's
and then they just highlighted again that it wasn't research, but given the dearth of research on late preterm infants, there's an urgent need for well-designed studies, specifically randomized controlled trials to identify hospital-based strategies to equitably increase breastfeeding in this growing population.
Yes. And I think in addition to breastfeeding, just reducing the risk of readmission, the frustration, that I think that these babies are probably much more prone to supplementation when they leave the hospital by their primary care physicians who don't understand that it's oftentimes a transfer issue and not a milk production issue. And so lactation is not optimally supported. And so, it's kind of a mess. And then patients think there's something wrong with them, or the parents think there's something wrong with them, or they don't know how to wake up their babies, or they don't know how to feed their babies properly. And when they find out, oh, wait, your baby's premature and they don't know it, because they're just being cared for like everyone else, then it's an aha moment for them. But I think this is...
and I think it really helps. Like they highlighted the difference in physiology, but they didn't highlight the difference in anatomy. Like sometimes these babies are just small and physically it is more difficult for them to get a deep latch. And it's really easy to explain to parents, like they're going to grow, their mouth is going to get bigger, they're going to get better at this. And it's a great way to then frame and normalize, and they're going to wake up and they're going to get better. And I think it's so important to explain that this is temporary. It's not that your baby's a bad breastfeeder. It's that they came early and it's going to change. I mean, to me, it is very similar to the frustration I have when parents in the postpartum unit are told that they have flat nipples. If we just said,
Mhm.
right now you're really swollen and it's making it harder for the baby to grab on,
Right.
then people think it's temporary. If I say to someone, you have flat nipples, they think they have a permanent lactation disability that is not going to ever
Right.
resolve.
I think this is such a booby trap in so many different ways. This sort of object permanence of like, this is the way it is. Like, my baby can't latch. My baby couldn't latch. I hear that story all the time, and you probably do too. My baby couldn't latch, so I just pumped for a year. I mean, like, really,
I
my baby
mean,
couldn't latch that day or that week, and so I oftentimes say, your baby eventually is going to walk and talk and pick up the phone and order a pizza. Your baby can't do it now, but your baby's going to do that. So in the same way, your baby is going to then latch in the next month. Like, just because your baby can't order pizza today doesn't mean your baby will never order a pizza. That's usually what I'll say.
that's a great way to say it. And I think it's just so difficult because of the dependency, the symbiotic relationship and the dependency on the parent to have milk removed in order to get the production up. And that really puts people behind the eight ball if their baby isn't able to do it.
Right.
And the focus on pumping sometimes is just really getting in the way. And I do, love the idea of having people hand express on day one, because if these late preterm babies get small volumes on day one, then they don't have concerning weight loss on day three. And it's not, oh, let's give them enough to catch up at that point. And I think it's really helpful, the idea that, yeah, it's okay if you need to give a little bit of donor milk, but it needs to be a little bit, and we need to reassess it and not just bring an ounce every 3 hours, which is what happens where I am, which is crazy pants.
Yeah, and also just, practicing that hand expression is so great. Like, I'm amazed at how many patients I see who are nursing like a toddler who've never learned how to hand express.
Oh,
Yeah.
nobody learns how to hand express, and so many people are taught incorrectly. I mean, I greatly respect Jane Morton and all the hard work she has done, but if I could take that video of the Band-Aid, the circle Band-Aids off of the internet from the Stanford website, I would, because that is not where babies latch onto the breast. We shouldn't be pushing out there so wide on the gland. It's really about softening the areola so that the baby can get their gums close enough together over the tubes to bring out the milk. And I think the video, for anybody listening who hasn't watched it, from Breastfeeding Medicine of Northeast Ohio, bfmedneo.com, is a really great breast massage and hand expression video.
Yeah, that's a good video. And if people have trouble finding that, they can just Google Ann Witt, WITT, breastfeeding video, and you'll find it. That's how I oftentimes will just find it. But yeah, that's a great resource. Yeah, some more work on that. I think my guess is that there are a lot of hospitals that are doing special protocols for late preterms. We just don't have a lot of, there's some research, and I don't know that data really well, but I think it should just be formalized in general. Great.
Yeah, I mean, this is the sort of place where, the different governing bodies make a recommendation, and that helps to push forward the hospitals that are not quite as, well, they don't have Kate Standish there.
Right, exactly. Yeah, and Bobby Phillip, yeah.
Yeah, both of them, they're great.
And Muirwood, the whole gang. Great. Okay, so I'm gonna turn to another topic, which is, of course, something about infant feeding, right? Because that's what our podcast is. This is called Humanity's Evolved Nest and its relation to cardiac vagal regulation in the first years of life. And this was published in Early Human Development in 2024, issue 193. And the authors are Mary Tarsha and Darcia Narvaez, and they're in the Department of Psychology at University of Notre Dame here in the United States. And so what they introduce in this paper is the concept of the evolved developmental niche. And they state that, and I would just jump ahead and just say what we're talking about is the niche that we create for our young when they're first born, and how influential that is in later development, and how breastfeeding plays a really important role in that evolved niche, and specifically about the normal development of the vagal nerve. And we'll talk about why that's so important. But they say that this evolved developmental niche is a million years old developmental system that basically matches the maturation schedule of the offspring, and that every single animal on Earth has some sort of developmental niche, right? And we study that, right? You can look at like what happens to baby ducks, what happens to the baby birds in the nest, the robins that are, in the nest in the tree outside your window, or what happens to the baby turtles, when they're like in the sand and they erupt, when the moon, and they run to the ocean, and all things. Like, we study all those things, right? And we consider them normal, and we don't think about, oh, what if we change how these baby turtles emerge out of the sand and see if we can get better outcomes, right? We sort of know, like, we need to like preserve that natural developmental niche for them to survive, right? And what these authors are saying is like, why do we try to like manipulate all these different things like sleep training, when that's not part of the developmental niche, is to leave the baby alone in a separate place and just let them cry it out? That's not a developmental niche. That's not how we have evolved. So that's kind of going, a little bit off tangent, but essentially they do talk a little bit about that. So they explain how aspects of the evolved developmental niche are important for vagal nerve function. And so just as a reminder, and and many of our readers know, that our autonomic nervous system has both a sympathetic and a parasympathetic pathway. And the parasympathetic pathway is stimulated by vagal tone, which basically calms our heart, it slows it, it influences anti-inflammatory effects in our body, it calms the lungs, just like the deep breathing that you would do if you're having an asthma attack, right? Or stridor. The liver, it affects tone of the liver, the GI tract, of course, and the immune system. And the vagus nerve also functions to conserve energy by increasing calming and restorative properties, both physiologically and cognitively, after experiencing stress. So the vagus nerve is also considered to be a critical neurologic component of like how we engage socially, because it controls our ability to regulate, right? So we can pay attention, we can control our emotions, we can have some sort of self-regulation, we can communicate well. When you're feeling famished and you're just stressed, it's hard to get your words out, it's hard to think straight, right? And by having good vagal tone, you actually can engage in social behavior in what one would consider in a civilized way, right? Where you relate well to others. So when the vagus nerve is developed well, this facilitates executive functioning skills and healthy social adjustment, including, again, that emotional and self-regulatory capacity. And they hypothesize, based on studies, that dysregulation of the vagus nerve contributes to things like post-traumatic stress disorder, attachment disorders that you may see in children who have had a very stressful life in the first couple months, particularly for those, for example, it's been well documented among children who've been adopted, obesity, eating disorders, migraines, depression, ADHD, autism, and dysregulation can also predict aggressive behavior in children. So they argue that the evolved developmental niche shapes a child's cardiac vagal regulation. And they cite a study that a child who experiences the evolved developmental niche in the first several months in the way that it's designed to be is really better able to demonstrate resiliency to childhood trauma that may happen later. And I found that to be really fascinating, because I don't know if you've ever read that book, What Happened to You? It's a book that was co-written by Oprah Winfrey and the psychiatrist, Dr. Perry. And Dr. Perry has been studying brain effects of childhood trauma for a long time. And what he says in the book, in this conversation with Oprah Winfrey, is that childhood trauma is most impactful in the first 2 months of life, and that childhood trauma later is not as impactful for a child if they had, and he didn't use the term, the evolved developmental niche, but I think that that's probably what he's talking about, is having that really nurtured environment early allows children to have that resiliency later. So what is the evolved developmental niche? So it has 5 components according to these authors. One is direct infant feeding, not pumping bottle feeding, but direct breastfeeding, and I'll talk about why they say that. The other is positive touch and being held close and being held frequently, and having caregivers respond appropriately and promptly rather than letting babies just cry it out and not having that sense of, not having anyone respond to them. Having multiple caregivers who substitute for mom, so what are called allo mothers, like others, like a village basically to support them. And then free play, I thought was interesting as well, just being able to play in a group with a variety of age people. So in terms of the role of breastfeeding, the authors discuss that the vagus nerve has 2 branches, the ventral branch and the dorsal vagal circuit. And breastfeeding plays an important role in the maturity of the vagal nerve. So the ventral branch connects the regulation of the striated muscles of the face with the larynx and the autonomic nervous system, which facilitates the connection between the heart, the voice, emotions, and face. So as a newborn feeds, the vagus nerve is stimulated by ingestion and the vagal reflex, like the muscles of the face, head, and neck, which activates the social engagement system. And it facilitates that engagement with the mother's face and provides the infant with this parasympathetic experience of relaxation, which is probably why babies always fall asleep when they're at the breast versus, when they're bottle fed. And this kind of physiologic regulation calms, soothes, and provides this homeostasis that keeps the infant in their growth state. And so this ingestion vagal reflex is considered to be an important part of the infant caregiver bonding process and paramount for development of infant regulation in general. So basically there's increased vagal activity. What they're basically saying is that there's more vagal activity in a positive way with breastfeeding than with bottle feeding. And some of this has to do with how the infant is being held with this face-heart connection. There's this warm reciprocal interaction between the infant and the mother. And, when we watch people breastfeed, they're oftentimes stroking their infant and, they oftentimes have this really loving touch, which I observe that constantly. They're brushing their hair, stroking their cheek, which is super positive. And so again, training this vagus nerve, like really what they're doing is they're just like promoting this parasympathetic development every time they're breastfeeding. And so so that's basically what they're saying, is that breastfeeding exercises the vagus nerve. And they also say that several studies have shown that breastfed babies have a more relaxed resting vagal function. And they feel like also the peristalsis of the tongue and the way that babies feed also adds to that vagal development, as opposed to bottle feeding, which they say is more like just using vacuum and not using their tongue peristalsis as much, which I don't know if that's really true, but I thought, maybe that's a stretch. But they feel that the parasympathetic pathway is not as well developed if a baby is bottle fed. So I thought that was really interesting. And, there are these studies that show that infants who are breastfed, children who are breastfed tend to be more kind of have less aggressive behavior. Perhaps there's less ADHD. Basically, children seem to have more resilience. And I think this is just super interesting and something to think about when we talk about the difference between direct breastfeeding and bottle feeding, and maybe ways that we could be nurturing babies more who are bottle fed, such as holding them, gazing into their eyes. Pacing can help that. But I'm going to use this concept in my toolbox when I talk about like not propping bottles and holding the baby and gazing into their eyes and stroking them when they're feeding, to really groom that parasympathetic pathway.
That is fascinating.
Yeah, isn't it? I love the connection between, we talk about bonding. We say, oh yeah, breastfeeding is good for bonding, but like, what does that really mean? And I'm just, again, fascinated with the research on that development in the first couple months that Dr. Perry has found, and then this other research on the vagus nerve development.
Well, and it also really makes me curious about, this idea that I love to teach the medical students. And I say to them, like breastfeeding, when we think about the health outcomes for children, there are, some really well-known things about decreasing infection and those sorts of things, but there's more evidence that, it has a longer term effect on heart disease. And so if you think about, like, I like to say, let's say you have an adult who has high cholesterol, and I'm like, please stop eating so much bacon and take the statin. While they do those things, their cholesterol will be better. But when they stop doing those things and go back to their old ways, their cholesterol will be worse again. But for a person who is breastfed as a child, it can have impacts on their cardiovascular health and their aortic elasticity 30 years later.
Right, exactly.
And so I wonder how much of that is nutritional and how much of it is related to this idea and
Right.
stress and, the nervous system innervation of our heart and lungs is so related to our sympathetic and parasympathetic. My son was like, well, why are my hands shaking after he took his albuterol? And we were having this whole discussion just recently about like the parasympathetic and the sympathetic. But it's fascinating.
Well, and I think the other thing that they mentioned, like in their background, they talk about this is a quote actually in the background. The impression given by too many scientists is that we do not know how babies should be treated until we have done adequate empirical experiments. Research experiments are not the first place to consult for guidance on how to support a healthy primal adaptive system. Humanity already developed the appropriate support system for human infants over the course of evolution, the evolved nest or evolved developmental niche. So what they say is if we go back and look at societies like Aboriginal societies where infants are always carried and they're nursing, 20 times a day, constantly at the breast, or just right here all the time. That's our like evolved niche, right? It's not the snoo, and it's not, bottles propped, like it's not crying it out. It's, all of those things disrupt that evolved developmental niche, and it probably
Oh,
has an important these things have negative effects on the vagal nerve. And we need to go back to recognize like, this is what we've been proven, just like breastfeeding. Like, why would we do all these experiments to see if formula is as good as breast milk when we have evolved with breast milk to make like for our species to survive? Why would you like take that apart? Because you want to make money is really the reason.
well, I mean, this also reminds me of Raylene Phillips does this wonderful talk where she, shows this. I think been some pretty awful research done on different mammals in the past of like, they took away the baby horse from the mom for the first hour, and then
Oh,
the
yes,
baby continued to have attachment problems forever.
yes.
And with, baby monkeys and those sorts of things. And I mean, it is true for us as well. We are mammals. And when people ask me the question of like, oh, my baby's falling asleep at the breast and how long should this last? And so many things, like I often will say, the baby kittens, they lay there all day long by the baby cat, right, by the mama cat, and they sort of sleep and nurse and sleep and nurse. This is what mammals are supposed to do. And, just normalizing it and trying to balance the research that we do have around sleep safety and help people to understand and to help pediatricians understand that, I like to joke a lot that we in America like to teach sleep safety a little bit like we were teaching abstinence only sex education. Like,
Right.
just don't do it. Don't fall asleep with your
Right.
baby. But like,
Right.
people who never planned to sleep with their babies are going to fall asleep. People tell us
Yes.
they do. They're tired. And so
Right.
we need to have conversations around like, this is normal. this is safer on a firm, flat surface than being on the couch.
Right. But also now people can say, oh, your baby falls asleep at the breast. Congratulations, you are developing your baby's parasympathetic nervous system. This is so good for your baby in the long run. Congratulations. Maybe that'll win some points and they'll just like chill and cool down and just, not worry about all the social media and all the other things that they have to do and just sit on the couch and nurse the babies. So
yeah, it's hard. There's a lot of pressure on people to go back to work after 5 minutes.
Yeah, this is terrible. Well, great discussion. I'm looking forward to our next podcast and we'll talk soon.
Sounds good, Anne. Have a great day.
Yeah, you too. Take care. Bye.
For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.